to Checkup, the medical information program that deals with common and not so common illnesses. During Checkup, we will be talking with experts in many areas of medicine. These physicians, who are on the staff of Mount Sinai Medical Center of Greater Miami, are going to bring us up to date on the state of the art in their specialties. Today, we're very fortunate to have with us Dr. Arthur Shapiro, Chairman of the Department of Gynecology and Obstetrics at Mount Sinai Medical Center in Greater Miami. Hello, Dr. Shapiro. We're glad you could be with us today.
Morning.
You know, I remember for years and years the discussion of fertility and things like that was definitely a no-no socially and in the press and everything else. And today we read so much about multiple births that are a result of problems with infertility and so forth and so on. Can you tell us, first of all, what infertility is?
Well, with any disease entity, one must have some parameters to deal with. And fertility is defined as inability to conceive or bring forth a baby after trying for 1 year. Now, there is some scientific reason for that definition, in that it would take approximately 6 months for normal couples to conceive, 2 out of 3 normal couples to conceive. So if a couple that are supposedly normal in their respective fertility, 2/3 of them will conceive within 6 months. And then the percentages go up a few percentages every month, so that by the end of about 10 or 12 months, those that can conceive easily, so to speak, or do not have a problem, will have conceived, which leaves a percentage of about 15% of couples that are involuntarily childless in terms of a definition for infertility.
I see. So that, in other words, if a person tries to have a couple tries to have a child for a year and they don't succeed, then they can recognize that there is some problem.
Yes. On the other hand, the couple may have a recognized problem previously, which would prompt them to seek attention earlier. As an example, if the wife, for instance, is not having regular cycles, that would maybe prompt her to see somebody at an earlier stage, because she knows without having regular menstrual cycles, she may not indeed be ovulating. So then, in that particular case, for instance, one would not wait the full year to find out that she can indeed conceive.
What are some of the commonest causes of infertility in couples today?
Well, we can divide them up certainly between male and female to start with. That's always a good division. And probably about 35 to 40% of the problems of infertility are, let's say, the male factor, so to speak. There may be also situations in which there may be more than one problem, so that in about 1/3 of the cases, more than one problem would exist, be it a male and a female problem.
Do you find that there's a macho problem with men admitting that they might possibly have a problem, or in going for testing?
In certain ethnic backgrounds, I would say that sometimes presents a problem. It also sometimes presents a problem in certain religious aspects in terms of how to obtain the semen sample. As you know, in the very orthodox religion, you cannot really obtain samples by masturbation. This is forbidden in Orthodox religion, Jewish religion. There are other ways of getting around it, though, with use of special condoms. You cannot use the birth control condoms because that actually will kill the sperm, but there are some newer condoms that are made in such a way that they can obtain the sample by having sexual relations and be able to test it from there. But that's, for instance, one parameter. So it may be a religious parameter in certain aspects in which you want to discuss it with the person's clergy, or it may be just a problem of, like you say, the macho image or the ethnic background, in which case you would like certainly initially to discuss their problem as a couple. And we certainly encourage the initial interview to have both the man and the wife present for that initial interview.
You find, well, I guess it goes back to the same thing. Do wives ever tell you that their husbands will not come, and then you just deal with the wife's problems alone? And what are some of the most common female problems? I'm jumbling up all my questions to you, I'm sorry.
Well, yeah, there are situations where that does arise. I would say right now it seems to be more the exception, where a husband just outright refuses to come. I would say that's really an exceptional situation. And in which case, one would have to think that certain problems exist in the relationship, in the communication of the couple, which may or may not have anything to do with their particular infertility infertility problem, but their stability of their relationship may be not that good or that intact and may represent some deep underlying problem in their marriage. On the other hand, in terms of your second question, some of the women problems, common one, of course, would be a tubal problem. Now, the tubal problem meaning that there was at one stage some inflammation that went on in the pelvis, be it due to an intrauterine device that was used, be it due to a sexual transmitted disease. And we know that there are now bacteria that are not only the gonorrheal type, which we're acquainted with, but other types of bacteria that can cause more subtle pelvic infections that may not even be as symptomatic as the gonorrheal type pelvic infections that can lead to an infertility problem due to the tubal adhesions or tubal scar tissue or the closing up of the fallopian tubes.
Can that correct itself, or does one have to have some medical procedures to correct a closed up?
If a patient has had an inflammation in the past or infection, a pelvic infection in the past, it does not necessarily mean that she is sterile. But of course this would possibly be associated, and certainly if she's had repeated episodes of an infection, that she may have an infertility problem. This is not correctable in most cases without some sort of surgical procedure.
That's a hospitalization procedure, or can the patient do it on an ambulatory basis?
Well, the testing for a tubal problem is two types. One is to undergo an X-ray, and this is done as an outpatient in the X-ray department, in which a dye or a liquid that shows up on the X-ray is put in through the cervix, and it shows the cavity of the uterus and the tubes themselves being the opening of the tube, and that the liquid spills out the end of the tube. Now this just means that you have an open tube. It does not necessarily rule out any adhesions or scar tissue around the tube. Following that, there is an ambulatory procedure that we do in Mount Sinai's ambulatory operating room, which we just opened this year, as a matter of fact, which we can now have an ambulatory surgical procedure. Obviously
by ambulatory, you mean they come in and they go out the same day?
Right. In other words, the ambulatory operating room are patients that do not stay overnight. They come in the morning or whenever this surgery is scheduled, and the intention is to send them home the same day, even though they may be having a general anesthetic. Now, the procedure that's done as the most diagnostic type of procedure is what we call a laparoscopy, where the patient is usually put asleep as with a general anesthetic, and a tube is passed in through the navel, in which one can visualize her ovaries, tubes, and anything that we want to see inside the abdomen, as good as you could be seeing it with an actual incision. The advantage is that because of the small incision that's made, that's less than an inch, one can send this patient home as soon as she recovers from the anesthetic. Now, we have been developing various tools to try to do surgery through this type of procedure. In other words, you can diagnose the problem, and now one would like to try and do some surgical procedure with this problem. One, in order to avoid a major operation, and two, in order to avoid a hospitalization. We have been developing, of course, all types of scissors and things that we can pass through the instrument, but lately, in the last year, we've now had, through development with the laser industries, which supplies our laser equipment, instruments that can be passed with the laparoscope, in conjunction with the laparoscope, that can vaporize through the laser beam these adhesions, and as long as they're not too extensive. So we have now also other tools that we can use with the laparoscope that can be actual as surgical procedure.
Besides the tubular problem, is there some other very common, are there other very common problems, or is that really the outside?
No, there are other problems as well. The other problems would relate to, let's say, ovulation. Somebody may be having even regular cycles, be unaware of the fact that she may have some defect in the ovulation.
And is that medicinally correctable?
Luckily, that's usually a problem that we can correct.
I don't know if there's a word medicinally.
Pharmacologically or whatever.
That's a mouthful.
There are medications, of course. These are ubiquitously known as the fertility drugs. And of course, fertility drugs really refer only to those medications that are involved with treatment of ovulation problems or ovulation defects. These are the clomiphene drugs, the Pergonal shots that you've read about, of course.
Are those the ones that cause the multiple births?
The clomiphene pills have an incidence of multiple births only about 5 or 8% of the time, and in the 99% of the cases, it's usually twins. Now, we have had triplets, and we've recently had a case of quadruplets with a patient who've had clomiphene therapy.
Because they get so much publicity that one is tempted to, has a tendency to think that almost everybody who's on a fertility drug has multiple births, but that's not the case.
Of course, because when this patient, for instance, with the quadruplets delivered, everyone who was on clomiphene got very upset and nervous that they might be. And
but the incidence is really not that great.
Very, very minuscule, very minuscule. 5 to 8% are twins. Now, when you go to the shots, the fertility shots, then you have a different situation. You do have there an incidence of about 25% twins. You also have about 5% triplets. And of course you can get...
But it's still very minimal, isn't it?
Well,
percentage?
Percentage-wise, in other words, the great majority of patients who do conceive have a single baby.
Is there any simple explanation that we could understand as to why the fertility drugs do cause multiple births?
Yes, which in fact would lead me into discussing one of the newer drugs that are around.
That would be exciting.
Yes. The reason for the multiple births is that you are using artificial mechanisms to stimulate either the ovaries or the pituitary gland, which is the gland behind the eyes that control the ovaries. Clomiphene, the pill clomiphene, is a stimulant to the pituitary gland, and it's an artificial stimulant. It's a pill that artificially stimulates it. And the feedback mechanisms or the control mechanisms on the body are bypassed, so that this stimulation bypasses the feedback mechanism in a lot of cases, or a control mechanism that causes 99.9% of the time that the woman only puts out one egg.
I see.
Bypassing these feedback mechanisms, the patient is now predisposed to putting out more than one egg. So that these multiple births now are identical, are not identical. They're non-identical twins or non-identical triplets. That's why you can have boys and girls in these births, because these are from separate eggs, different from the identical twin problem. In the shots, of course, these are shots that bypass everything and just stimulate the ovaries directly. So you've bypassed all the control mechanisms that are built into the body that allow only one egg to be produced.
Fantastic. The body knows what to do if it's left alone.
Now, what we're trying to do with some of these fertility problems is to reinstitute a situation where we have the body's control of ovulation, putting out the egg, reproduce, so to speak. And this is a newer drug that comes from another brain center. There's one center above the pituitary gland.
Is it a synthetic drug, or is it?
This is synthetically made, but it's identical to the drug how it's manufactured in the brain itself. It's called releasing hormone, and this releasing hormone stimulates the pituitary normally in the normal ovulation.
It causes the body to do what it wasn't doing on its own.
Well, in the normal woman, she does get this stimulation to the pituitary gland from this releasing hormone. The pituitary gland, in turn, stimulates the ovaries. Now, what the new drug, the synthetic of this releasing hormone, which is identical to the natural hormone.
Is it being used, or is it still in the testing?
Well, that's what I'm going to discuss with you right now. The natural hormone is identical to the synthetic and can be used to stimulate the pituitary gland, leaving intact all the control mechanisms in the body. The only drawback for this is, one, it's in a research situation right now, but Mount Sinai is one of the centers that is involved with the Airst Pharmaceutical in evaluating this drug. The drawback to the drug is that although it's very safe from our initial and everyone else's experience with it, is that it must be given every 2 hours around the clock, which presents a technical problem. And there have been pumps that have been developed which can actually administer the medication on an every 2-hour basis around the clock.
Is it taken orally or by injection?
By injection, and this can be either in the vein, and we're also evaluating it to put just as a needle under the skin, which makes it a little simpler. So the drawback is the way in which the drug must be given, not so much that we have the drug around that we know it can work.
That's fascinating, absolutely. And you're doing it at Mount Sinai?
Oh, yes. Mount Sinai is one of the centers that are involved with the pharmaceutical company.
That's marvelous. Tell me, how much of a factor do you think how important do you think the psychological factor is in infertility? I'm probably not asking that right, but...
I think I understand what you're getting at. I think that the psychological factor is there. Whether or not there's a cause and effect is a difficult question to answer, and may possibly have an influence on the fertility itself. But more importantly, fertility itself is a psychological stress to both the man and the wife. It also presents a difficult problem for both the man and the wife to face, and can in fact lead to if the marriage itself is not on a strong basis, have a strong foundation, can lead to a lot of difficulties between the man and the wife. In that aspect, you must be constantly aware of the fact that psychological situations or emotional situations are very keen or very important in the evaluation of an infertility problem of the couple, and must be aware of that if you're ordering a test, or that situations may arise, and for instance where the husband is unable to have relations with his wife purely from the basis of because of this infertility and the pressure, and he must perform on a certain date, and we have to be constantly aware that this complication may in fact ensue, and is easily curable by just having the husband come in and discuss the problem and make him understand that this is not an unusual situation, and that he has to understand that many men suffer from this. Just the idea of assuring him that this is a common...
He's not abnormal in any way.
Usually is curative in itself.
That's right. I wonder if are there any statistics about infertility in more primitive societies as opposed to infertility problems in societies such as ours, where everybody's operating under a certain amount of stress, and women have careers and men are under pressure, and keeping up with the Joneses is a serious problem, and all the stresses in today's society, if that's causing an increase in infertility?
I would say, to answer your question, I would give it a generalized yes in terms of the stresses affecting fertility. We know that from the semen analysis patterns, we have what we call a stress pattern, which can show up in the semen analysis. In other words, when we analyze the sample that the husband submits, that there is stress patterns that are very suggestive that if you can somehow relieve the stress that this person is under, his analysis may improve. So we know, we are acquainted with that fact. We also know that stress can in fact cause ovulation problems in women. The problems of, for instance, the athletes or the heavy, the women who are engaged in heavy type of athletic activities, and I mean jogging 7-8 miles a day, may in fact produce some ovulation defects in certain women. It doesn't mean that every woman or every man who's under stress or every person who's jogging that amount of time is going to have a problem. In the woman, it's more easy to recognize when she's not having regular cycles. In the man, of course, it may be more subtle. The stress may in fact produce a problem of being able to have sexual relations, and also that the semen analysis itself or the characteristics of the sperm may be such that they may be abnormal. The other disease entity that has probably been written a lot about is possibly related to the pattern of the woman's stressful pattern is endometriosis, which is a whole different subject, but is related to infertility.
Would you say that word again?
Endometriosis.
And what does that mean?
Well, that's what I was going to tell you.
Fine, I'm sorry.
This is related to the problems that have been seen in women that have put off pregnancy. Now the question arises, is it just the putting off of pregnancy that produces this problem in certain susceptible women, or is it the type of lifestyle that these particular women are leading, being the executive and the more stressed type pattern, that produces this problem? My particular feeling is that there's a lot of housewives that are under a lot of stress who don't develop this problem. So I don't think that the stress per se is related to it, although a lot of people have felt that there are, quote, personality types that develop this disease. But this disease is one in which the types of cells that exist inside the lining of the uterus begin to develop in other areas outside of the uterus, meaning around the ovaries, around the tubes, and cause a sticking of the organs to one another, and this promotes an infertility problem. This is again seen, as I said, in women who usually have put off having their pregnancy till the early 30s and so on. The characteristics of this is a patient who comes in with not only an infertility problem, but symptoms of having increasing amounts of pain at the time of her menstruation, at the time of other times during her menstrual cycle. So pain and infertility may mean some sort of pelvic inflammation, or may mean that this patient has endometriosis.
Well, if the patient does have endometriosis, how do you treat that?
There again, it varies in terms of the type of problem that she has. We diagnose the problem only by laparoscopy, which I already described what that is. Depending on the extent of the disease, we can sometimes cure it medically. We have a medication that suppresses the problem, that allows it to degenerate or involute. We also can have a surgical procedure if there's extensive amount of scar tissue. Now again, getting back to the laser, we were able to attach the laser to the laparoscope, so in the more milder cases of endometriosis, we can actually vaporize these cells through the laser beam, eliminate a lot of the scar tissue, and the patient's home the same day.
Oh, that's fantastic. Do you all ever use tranquilizers when a person is, when a woman is getting so tense about the whole thing and you are not finding any real physical problems? Is there any kind of psychological medication or therapy that you recommend?
First of all, I think it's very important to have the lines of communication open, not only between the doctor and the wife, but the doctor and the couple as a couple, and of course have the wife and the husband having clear lines of communication. And the physician's role here is to be a catalyst to make sure that these lines of communications are there. And this deflates a lot of the stress and a lot of the problems that can relate to it. The use of drugs is really frowned upon for a couple of reasons. One, it does at times interfere with the cycle if it's used in certain patients that are more susceptible to these problems. Two, if the patient should conceive and she's on this medication, one is very aware of the fact that some of these tranquilizers have been associated with some fetal problems, although the incidences are still small. So one would like to keep away from using the tranquilizers, and certainly to have a patient dependent on every time she gets upset or stressed to pop a pill, excuse me, would not be the best method that we would like to see being carried out. So I think the lines of communication and keeping an open line of communication and being able to have the husband and the wife and the physician be interrelating with the problems as they arise are more important.
How long a period of time does it usually take from the time a person discovers or realizes they have a problem, a couple, and they come to you for testing? How long is the average period of time, if there is such a thing, until some results or decision has been reached?
Because of the nature of the tests that are involved, and there's only maybe 3 or 4 screening, let's say 4 screening tests that are involved, but because of the nature of the tests that they must be done at different times of the cycle, it may take 3 or 4 cycles or so to diagnose and maybe to reconfirm by repeating the test the problem. So I would say 3 to 4 months is usually enough to get all the tests and all the results together.
And then the treatment, there's no set time for the treatment?
Well, there is really a set time for the treatment. I think that if the patient has had 6 months of a treatment where you feel that that is the problem and you've explored all the other avenues of causes, one reevaluates the situation to make sure why after 6 months she is not conceiving.
So it's about a year.
And then maybe reinstitute another 6 months. So by the end of 1 year, or if you include the stage of workup as well, where you're doing the testing, so by 1 year to 18 months, we either have the patient pregnant or we've advised her to use other modalities.
I was just going to ask you at what point you suggest that they either adopt or adapt to the situation.
Well, I think about after 1 year of treatment, if something has not come up that needs to be retreated or something new has arisen in the patient's situation, after 1 year of intensive treatment, I would say that that's about where we stop.
You know, it's so strange. So often we hear of couples who tried for 15 or 16 years to have children and had no success. They adopt a child, and lo and behold, the lady in a very short period of time is pregnant. Is there any logical explanation for this?
I think some of this may be, of course, that the couples become less intense over this infertility problem, and maybe have an improvement in their relationship, which has been under tremendous stress. I don't think it's the adoption per se that leads to it, and there are statistics that show time factors. It's just a matter of time before certain patients, let's say, who have no real cause of their infertility will eventually conceive. If you follow them out for 5 or 10 years, there is a given percentage of patients that will conceive within the 5 or 10 year period. In those cases where one has not, let's say, discovered a problem but has given up treatment, so to speak. So there is a definite percentage of these patients, maybe a third, that will conceive on their own in spite of the fact that
whether
nobody...
they had adopted or not.
Right, exactly. So I think there's a matter of a time sequence involved here.
I used to wonder maybe having the child stirred up certain juices that then created hormones or something like that, but that's probably an old wives' tale.
Well, it's nice to think of it that way, but probably it's a matter of time and statistics that explain the reason.
Tell me, do you think that some of our modern birth control devices are causing an increase in infertility on the part of women, or do you think that the problem has been existent? We just haven't kept the statistics and haven't been as aware of it because, as I said earlier, it wasn't a commonly discussed thing.
To answer that, I would say, again, that as a generalized affirmative, the situation with, for instance, intrauterine devices, those plastic things that are put into the uterus for contraception, there is no doubt now from the statistic that there is about 7- or 8-fold increase in pelvic infections in those women. Now, the question is really, is it from the device itself, or is it that this device is a stimulant to having more extensive pelvic infection if the woman becomes exposed to the appropriate bacteria that cause pelvic infections? So I think, to answer the question, it would be that probably these devices in and of themselves are not the basic cause, but are a catalyst in causing more severe infections when the patient becomes exposed to the bacteria that can cause a pelvic infection. I think, on the other hand, birth controls pills are a little bit protective against patients having more extensive pelvic infections. But there's no doubt that the amount of pelvic infection has increased since the barrier methods like condoms and diaphragms have become less popular. When you had condoms and diaphragms being used, there was less dissemination of sexually transmitted diseases. And I think, therefore, now we're seeing a rise in the amount of pelvic or end stage of pelvic infections because we've of recently time, using less of the condom diaphragm type techniques, are more exposed, the women are more exposed to possibilities of getting these types of pelvic infections.
Fantastic. It's absolutely fascinating, the whole subject. I've never realized how many facets there were to treating this and diagnosing it and everything else. We've got about 20 seconds. Can you tell me if there's anything really new and exciting that we can look forward to in the field of solving infertility problems?
Well, I think that one, as the surgical techniques are going to be improved, we're already seeing an upsurge in using microscopic techniques. We're seeing an upsurge in using laser techniques and new medications that will be involved in fertility.
Wish we could keep talking. Thank you very much, Dr. Shapiro. It's been fascinating. We hope you'll join us next time on Checkup. Thank you.